some introduction about myself. I will go into what a day looks like and all of that. But I also wanted to give you guys an opportunity to kind of see some of the clinical medicine that we practice in anesthesiology and some of the thought process that we have in our specialty, as well as delve a little bit into the fact that I'm also an ICU doctor or an intensivist. So even though I'm an anesthesiologist, I can also be an ICU doctor with extra training. So thank you guys for inviting me. And I'm really excited to be able to share my experience and be able to share my specialty and all of that. So let's just get started. So first and foremost, I'm Amanda Shee. I am originally from Michigan. I'm from the Metro Detroit area, but I currently live in Boston. I had a little bit of a non-traditional path when I went through undergraduate and medical school, mostly because my fun fact always that I tell people is that I'm actually a high school dropout. I do not have my high school diploma because I went to college early and I had gotten a full scholarship to this early college in Western Massachusetts. So it was a big deal for me, at least, when I was 15 years old, deciding to drop out of high school and move to a completely new state and city and start college at that point. So I did that. And then after 2 years, I went ahead and transferred to the University of Michigan. What I'll say about that is that there are some challenges if any of you guys are transfer students or thinking about transferring, there's certain challenges with being pre-med and transferring colleges. So things to think about for sure. But I went to the University of Michigan. I finished my degree in biomedical engineering. So that's another kind of comment is that, many pre-meds tend to be more bio majors, things like that. But I was someone who really wanted to be practical. So I was really realistic. No one in my family is in medicine. No one's become a doctor. My parents immigrated to the US. So I was the first person to ever express interest in medicine. And no one could help guide me. So everything that I figured out to become a doctor was through the internet and through advisors here and there. So just be aware of that. And I also got my master's degree in biomedical engineering. I worked for a few months as an engineer before I got into Oakland University William Beaumont School of Medicine, which is another kind of non-traditional thing about me is that I went as part of the charter class to this medical school. So I went to a brand new medical school, and that was for a variety of reasons. I will say that when picking a medical school, I really don't think enough people talk about the finances and the financial side of things. A lot of people talk about how important it is to go to a brand name medical school, things like that. But I also think it's important to consider your support network, because being in medical school is really tiring. It's exhausting. It's something that no one else can really describe to you until you go through it. And so I think that as you guys are going through your journey, I think it's really important for you to consider, one, what is the location in which you're going to pick a medical school? Is it close to family support, something that you're passionate about so that you have the ability to have some kind of outlet or feel supported? And then two, again, finances. At the end of the day, it really depends on what your priorities are. If you are financially sound and have the ability to pay the $50,000 a year that it costs for tuition, then so be it. But I was not coming from that situation. And so the idea of having a scholarship, which I received, actually made a really big difference to me. One of the things that people always ask me about, because I went to a brand new medical school, is whether I was concerned about matching into a competitive specialty or matching into a really high-ranking program. And so one of the things that I will say is I was part of the charter class, first class ever of this medical school, and I got my first choice at one of the best anesthesia programs in the entire country. As a result of all of this, I will say that it doesn't necessarily matter where you go to medical school. However, there are certain medical schools that have brand names that take you further. So that is the reality of, I'd say, medicine and networking in general, is that, and like life in general, it's all about who you know and where you come from. So there are certain things, there's certain value placed on where you go, but typically where you go, unless it's like Harvard, Yale, and those crazy high level things, all the rest kind of are the same. So those are things to just consider as you think about, oh, should I go to this private school that's in my state or this public school that's in my state, even though they're both kind of equivalent in their name brand. Just consider that a lot of your success in residency match depends on you as an individual and not necessarily the medical school you go to. So I decided to do my internship separately from my anesthesia residency. So anesthesia actually is a 4-year residency, and there are certain programs where you can separate the internship away from the residency part, the specialty training, and that's the kind of path that I took. There's certain programs where all 4 years are in the same place, and that's another path that people can take. So I matched into Henry Ford for my intern year. So I spent a year close to home, living close to my parents, being able to go home and eat a meal that my parents made for me, but also be able to commute to work. It also meant that I really wanted to go there because I already had some interest in ICU and caring for ICU patients. And one of the authors of a landmark study that was published in the New England Journal of Medicine actually works at Henry Ford Hospital. So I knew I wanted to go and have an experience working with this particular physician, and that's a part of wanting to go there. Another thing too is that Henry Ford Hospital is in Detroit, which is a quite an underserved population in the United States, and that also influenced my decision to want to go there, because I think it's really important to find a place where you feel like you're really giving back to the community. And I felt like there I was able to do that. I then moved after a year in Detroit to Boston. And I will tell you guys that if you guys are coming from the California side, it's probably not a big deal, but I'm a Midwestern girl and Boston is expensive. So moving to Boston was a big culture shock. I was like, how much am I paying for my rent? This is like how much people make like monthly for their salary. Like some people only make this much money and that's how much I'm paying for rent. So it was a really big culture shock. The actual Boston area I felt like was very easy to get used to, but housing is crazy. And so I did residency at Mass General, which is the birthplace of anesthesia. We have the Ether Dome. And so it's a really special historic place to train in anesthesiology. And then afterwards, I stayed on for 1 extra year to do critical care medicine. So we'll kind of delve into a little more. So the big question, I mean, many of you guys probably have some interest in anesthesiology to be here, but I think it's important to kind of answer the question, what do we even do? So the definition from our specialty board, so the American Board of Anesthesiologists, define our specialty as individuals that evaluate, monitor, and supervise patient care before, during, and after surgery. So we are available, we're around to be able to, like when tomorrow, for example, when I go into the operating room beforehand, I know which patients I'm taking care of, what surgeries I'm going to be taking care of them for. And then I have to look through a patient's history and decide, okay, is this patient safe to undergo surgery? What are some things I need to worry about when I come up with my plan for anesthesia? And how does the surgery impact what kind of plan I make for anesthesia for that patient? Additionally, besides being in the operating room providing the anesthesia or supervising other people that do it, we also make sure that patients are safely on the other side in the recovery room, able to kind of go back to normal. So that's another area where we are also around. So we're not just in the operating room taking care of our patients, we also kind of care for them before and after as well. Other things, we lead an anesthesia care team. So I want to bring that up because what you'll find is that if you've ever had surgery, it's possible that you were cared for in the operating room by a nurse anesthetist. So there are certain models in which an anesthesiologist like myself, and in the model I currently practice, I will supervise multiple rooms and I will be overseeing the care that's being provided by a nurse anesthetist who is in the room. I'm also at an institution that has residents, so I will be supervising those residents as they go through their training program, and while the residents are at the bedside caring for the patients. Additionally, I can also practice where I will do the case completely by myself, taking care of the patient myself. Additionally, on top of that, we can go into different subspecialties. So we can go into pain management, and we can also do critical care medicine, which is what I do. Something I wanted to delve into is what do critical care anesthesiologists do? So what we do is we supervise, coordinate, and manage the patient's ICU or the patient's care within the ICU team. We work with consultants, we work with our surgeons, et cetera, et cetera. The biggest thing that I wanted to kind of explain about this is the fact that a lot of people have actually asked me, now that I've been doing these presentations, is like, oh, so you're an anesthesiologist in the ICU. And that's not actually correct. So I am the ICU doctor in there. I'm not acting, I will use the skills which I learned through anesthesia. So using a ventilator, being able to change that around, using vasopressors or medications that increase blood pressure. Those are all things that I'm very comfortable with from my anesthesia training. But in the ICU, I am the ICU doctor there. So I'm not acting in the role as an anesthesiologist. I am the ICU doctor. So I think that that's something I wanted to clarify to people, is that I wear two different hats. When I'm in the ICU, I work as the ICU doctor. When I'm in the operating room, I work as an anesthesiologist. Something I think is also important is that there's different specialties with different gender breakdowns. And what you'll find is that what's interesting is OB-GYN used to all be men, and then women started being admitted to medical school. And so now it's actually a very female-dominated field. Pediatrics is a female-dominated field. Many of you guys may know that surgery is a male-dominated field. And I'd say anesthesia is lacking a little bit in that, I think because we're working in a surgical type of environment, that women don't necessarily flock to our specialty. That being said, I still think it's a fabulous specialty for women. And so I encourage any of you guys to really consider and look into our field. How to become an anesthesiologist? Well, I've alluded to this already, in that you need to go to college in order to get a medical school. So get your bachelor's, get your degree. Some people will do other careers before going to medical school and go the non-traditional route. I have one of my co-residents was a Microsoft engineer for over a decade before going back to medical school. So it really, what matters is just that, you know, you have your degree and you have some experience. You go to medical school, you finish that. For us, like I kind of said earlier, you could do an internship separately from anesthesia. So that's 1 year, or combine it all into 4 years. And then all of our fellowships are optional. Some of my best friends decided not to do any fellowship at all. They just went into practice after 4 years, providing anesthesia. Or a lot of my colleagues also decided it's only 1 extra year to do a fellowship to be able to do specialized anesthesia care. Now, delving into the subspecialty component, we can do fellowships in all of these different areas. So cardiothoracic anesthesiology, so when patients undergo open heart surgery, you don't absolutely have to have this fellowship in order to provide the right kind of anesthesia for these patients. However, the majority, we're moving to a model where the majority of our anesthesiologists that care for patients that undergo open heart surgery or any kinds of cardiac surgery are cared for by cardiothoracic anesthesiologists. So getting the extra training is actually mostly because they have to specialize in something called transesophageal echo. So that's a camera that goes inside the esophagus to be able to take pictures of the heart. It's an ultrasound essentially of the heart from the inside. And that extra year of training allows them to get certification and knowledge to be able to interpret those images, to get the images, but also interpret them in order to guide surgery. Now, critical care anesthesiology, that's what I do. We'll delve a little more into that in a little bit. Neurosurgical anesthesiology, people can get extra training to be able to care for a neurosurgical patients that have high intracranial pressures or have masses or tumors in their brain. There's specialized kinds of anesthesia that we need to provide to these patients and specialized considerations for many of them. A lot of the time, a patient's first interaction with an anesthesiologist will actually be on OB when they give birth or when their partner gives birth. And so anesthesiologists are the ones that put in epidurals that allow for pain control and allow for relatively painless delivery of babies. We're also there to be able to provide anesthetics for a C-section and other kinds of deliveries on the OB floor. So we're a really big part of that team. We get a lot of knowledge, or we learn a lot about pain medications as well. And so we could do 2 different kinds of pain medicine subspecialty fellowships. So acute pain would be patients that undergo some kind of surgery in the hospital. They're still in the hospital and they need things like blocks, like nerve blocks. So many of you guys, if you've ever had surgery, probably had some kind of nerve block. If you've broken a bone in your lower extremity or broken a bone in your upper extremity, we can actually use numbing medicine around nerves to be able to take away pain. And that can be helpful for surgery and other kinds of injuries. Pediatric anesthesiology, obviously taking care of little kiddos, babies, preemies, et cetera, et cetera. And then finally, something that many people don't realize is that we can actually do a fellowship in palliative care, which I think is really interesting because we have so much expertise in pain medication and pain management that our expertise really lends itself well to the palliative care sphere. Now, you guys are shadowing today. I'm sure you're curious about what my day normally looks like. So I'm going to separate this into two different kinds of days. So in the operating room, the way that my hospital has set things up, my shift is from 7 a.m. to 5 p.m. Most anesthesiologists in big hospitals have more of a shift-based setup or schedule, whereas some of my colleagues that are in private practices or smaller hospitals, they are in a model such that they will stay until the end of the day if they're on call, so they need to finish off all the cases. That doesn't mean that for my situation that I always go home at 5 p.m. or at the end of my shift. I am someone who frequently likes to stay for big cases, or if a patient is very, very critically ill in the operating room, it's usually better to be able to care for the patient from the start to finish, just for patient care continuity. Anytime we hand off a patient to another person, there's a risk that something could get missed. So that's one of the reasons why I think it's really important to finish cases on patients that are really sick or cases that are really complex. So my schedule is 7 to 5. I generally get to the hospital a little before 7 a.m. I change it to scrubs, and then I go meet the patients that I'm going to be caring for in the preoperative area. We have to do a lot of paperwork. We get consents. We make sure that all of our paperwork is ready. We'll place an IV and we'll just do any other. Sometimes patients will undergo a block, that nerve block, before they go into surgery, shoulder replacements, knee replacements, things like that can get nerve blocks. And then by 8 a.m., usually that's when our first cases start. So we'll transport our patients into the operating room. We'll put on our monitors. We will go ahead and provide the anesthesia. And because I'm an attending now and I supervise other rooms, what will typically happen is that a nurse anesthetist or a resident will take the patient into the room. They will call me when they're ready to go to sleep. And then I come in and we go ahead and do what we call induction. That means going to sleep. So that induction and being able to manage an airway if someone is undergoing a general anesthetic are some of the most dangerous times in anesthesia. So that's the reason why I have to be present typically for those times of anesthesia. Once everyone is safely anesthetized, what you'll see here is that I don't really say anything else other than AM break, lunch break, and PM break, which sounds kind of funny, right? But an anesthesia provider has to be with the patient at any given time. So as someone who's supervising, what my day looks like is making sure that I see all of my patients that I'm going to be caring for, and that I make sure that the people that I'm supervising are able to get their breaks, because they can't just walk out. If you need to run to the restroom, you can't just walk out while your patient is anesthetized. You need to actually keep an eye on them. So someone else needs to be there in order to allow you to walk out. So that's something I like to highlight. And then by 5 p.m., if the cases are done a little early, sometimes we get to leave a little early. If they go past, sometimes they'll stay, and sometimes another person will come in to relieve me. The other thing, another typical day is I work in the ICU as a ICU doctor. And while the shift is similar at 7 a.m. to 5 p.m., it looks a little different because in the ICU, we have to do rounds rather than start surgery. So it's a very different look. So at 8:30 a.m. typically, we all congregate, and we being the ICU team. So I'm the attending. Usually I have a fellow, I have a resident. Sometimes I have nurse practitioners, medical students. We all go to each room. We involve the nurse that's caring for the patient, and we go over what has been happening to the patient and our plan for the day. So that's what rounds are, is how do we take care of this patient for the day to advance their care or be able to address any issues that are going on for these patients. Now, an ICU patient is someone that typically needs to be on either a ventilator or on special kinds of medications to keep their blood pressure up. Those are what we call ICU indications. If you don't need those things, then you typically are not in an ICU. I finish rounds sometime in around 11 a.m., sometimes earlier, sometimes later. It just depends how complicated our patients are. I also want to highlight any time during the time I'm in the hospital, our hospital has it set up that we carry an airway pager. So if there's someone in the hospital that suddenly can't breathe well or needs to be intubated, that something has changed there, they call us and we go to the bedside to assess the patient and do the procedure of intubation as needed. After that, we kind of get other work done. And then about an hour before we sign out our shift to the nighttime team, I'll walk around and catch up and see, what has happened throughout the day, and then follow up on anything that needs to happen at night. My colleagues will then come in at around 5 p.m. and I will hand off or basically give a sign out, meaning I tell them about all of my patients, what our plan was during the day, what happened, and things that they could anticipate needing to do at night. I wanted to bring up call because I think that this is important for you guys to be aware of in terms of a schedule and what a day looks like, because pretty much most specialties have some sort of call. Anesthesiologists have to be available in most major hospitals 24 hours a day, 365 days a year. And so that means that someone has to be there and someone needs to be working overnight. So we do take call. In my personal schedule, I do overnight shifts, but there are other models in which 24-hour call is what's employed, where you're in the hospital for 24 hours. But personally, I'm there from 5 p.m. to 7 a.m. and I usually do that a couple times a month, and that would be my call. Now, I wanted to delve into teaching you guys a little bit about the types of anesthesia that we can provide so that you have an idea of what we pretty much do. The most common type of anesthesia people think of when they hear anesthesia is general anesthesia. General anesthesia means that someone is completely asleep, they are unaware of what's going on in their surgery, and once we turn off the anesthesia, they wake up and we take out any kind of devices to help them breathe. Now, with general anesthesia, typically we need to assist someone's breathing. So as a result, we use something called an endotracheal tube in order to connect someone onto a ventilator. The endotracheal tube is placed using the procedure of intubation. So if you hear the term intubation, that means that we're placing a plastic straw or a tube in someone's trachea in order to hook them up to a ventilator or take over their breathing. The device that is being shown here in this image, that metal thing that's being held, is a laryngoscope. It literally is a handle with a metal blade at the end to move the tongue out of the way and provide a view of the glottis, which are the vocal cords, and that's where we place the endotracheal tube through. Another type of device that we can use for general anesthesia to help someone with their breathing and hook them up to the ventilator is called the laryngeal mask airway, or an LMA. This is like a squishy soft mask that sits in the back of the mouth. It does not go into the trachea or anywhere else, but it provides a way for us to hook up to the ventilator, either to allow a patient to breathe on their own or to be able to take over their breathing. The other thing to be aware of is that most of our anesthesia is actually provided through the ventilator. So people always ask, oh, is there any medicine? So, what I'll say is that if I go back to this slide, every time I get to this point, many patients are like, oh, is there any medicine in this mask? And there's no medicine in the mask. Unless you're a baby, most of the time there's no medicine in the mask. All of the anesthetic usually goes through the IV. And then once someone is asleep, then when they're hooked up to the ventilator, they receive anesthesia gases. You breathe in the anesthesia after you're asleep to keep the anesthesia going and to stay asleep. The other type of anesthesia we provide is monitored anesthesia care. So this is something where it's very close to sedation. If you've ever had your wisdom teeth out or things like that, that's a level of sedation, and that's how we kind of liken it to. Typically, patients are breathing on their own. We're not helping them breathe. We don't put any devices in. We don't hook them up to the ventilator and monitored anesthesia care, but we are there to be able to, the most important thing is convert to general anesthesia if we were to need it. So that's the difference between nursing sedation and an anesthesiologist doing monitored anesthesia care, is that in monitored anesthesia care, an anesthesiologist or care team member can change the type of anesthesia to a general anesthetic if needed. So that's a big difference there. Another thing I kind of alluded to earlier, our obstetric patients get epidurals and spinals very frequently. That's a type of anesthesia that we can use to get people through surgery. So as you guys may know, a cesarean section to deliver a baby is one way that we can do surgery under a spinal or epidural. Other things like lower extremity surgery. So if you get a knee replacement, a hip replacement, you can actually get that done under a spinal or epidural. They're two different things. So a spinal actually goes into a deeper space that has cerebral spinal fluid. In that fluid, we put some numbing medicine in there, and it allows for numbness to go all the way up to the chest area even. So patients don't feel anything during their surgery. The epidural is a little different. What we do with that one is it is a catheter, like a long, very, very thin straw that is placed into a space that is outside of that CSF space. And we get to leave the catheter in there. That means that we can provide medicine continuously so it lasts longer. So the spinal, after we put the medicine in, once it goes away, it's done, it's gone. We don't have a way to continue to dose medicine or provide more medicine. With an epidural, we can continue to give it. So if a OB patient is in labor for over 24 hours, they can have an epidural running for 24 hours. Another really important part of our practice are our monitors. And so we're trained especially to be able to keep an eye on our vital signs during surgery. And this is an important part of our practice. Another thing about monitoring is that there are certain procedures we sometimes need to do in order to achieve or get a type of monitor. So an arterial line is a special kind of catheter that goes into an artery instead of a vein. So if you get an IV, that typically goes into the crook of your arm here. It's in the little blue vessels, versus an arterial line is actually a little plastic tube that goes into a place with a pulse. So what you'll see here is that it goes into this radial artery. Many of you guys can feel your artery there. We put a line in there in order to be able to see someone's blood pressure every single time their heart squeezes. It also allows us to get blood draws from it, whereas an IV, you can't always get blood from after it's been in there for a while. A central line is another essentially very, very large IV that we typically place in a couple places. So either the neck, in the chest, or in the groin. Those are the three main places central lines can go in. It is a special kind of IV that can stay in longer, that actually we can put special medicines in. So our vasopressors, or medicines that allow for blood pressure to stay up, need to be delivered through a central line, because typically if they're delivered through a regular IV, if the IV were to infiltrate, that means it goes out of the vein. Then delivering the medicine to that sub-Q space or your skin can cause skin breakdown, damage. It can cause it to necrose. That means totally die off, and that's actually dangerous. So we want to avoid that, and as a result, we need to sometimes place a central line using ultrasound typically to allow us to deliver certain kinds of medicine. And another thing about our specialty is that we are great at pharmacology. We know medications very well. I like to say, are kind of the jack of all trades. So what I love about my specialty too is that, when I was on an airplane at one point internationally, we were on our way home and they asked for a doctor. I can be so many things besides just the anesthesiologist or doctor. So there's very few, actually the majority of doctors that know how to start an IV. So I place IVs because I'm an anesthesiologist and I can do that. There's very few doctors, or like no other kinds of doctors, that actually could draw up our own medications, deliver them on our own, because we're so comfortable with that. We can deliver fluids, all of these things. So typically a lot of doctors rely on their nurses and their pharmacists to be able to do these things. But as anesthesiologists, we do them every day in the operating room. So we're very comfortable being our own nurse, pharmacist, and doctor. So it's a really useful specialty. We're very useful on airplanes as well. So if you are ever on an airplane with a medical emergency, you want to look for an anesthesiologist. Okay. Now let's move on to, if you were hanging out with me today in the operating room, what is that going to potentially look like? Well, let's talk about, this is of course a made up case. I would never share patient information because of HIPAA. So we will just go through this kind of made up case and so you can get an idea of some of the things I think about as an anesthesiologist and that I see pretty frequently. So in this particular case, we're going to be caring for a 90-year-old male that has a right hip fracture after we say a mechanical fall while ambulating home. That means they probably tripped over something, they fell over, and then they broke their hip. This is a very common occurrence. And as a result, we care for these patients that need their hips fixed in the operating room. PMH means past medical history. So this patient has hypertension, moderate aortic stenosis, and hypertension means high blood pressure. Aortic stenosis, I'm going to go into in a little bit. And this particular patient is on metoprolol, which is beta blocker. It slows down the heart rate, and lisinopril, which is an ACE inhibitor, which actually lowers blood pressure. Every time we care for a patient, we have to examine them. We need to know what's going on with them. A physical exam really tells us a lot about a patient in terms of how we're going to be able to prepare for their anesthetic and other considerations that are not always readily accessible from the computer. So in this particular situation, this patient is a bit confused, which is pretty common for our elderly patients that are in the hospital. They frequently have delirium, which is confusion essentially, when they're in the hospital because there's a lot of lights and sounds and noises and they can't sleep and they're in weird places. And so that's a pretty common thing we see. This particular patient has dry mucous membranes, meaning you look at their lips and you notice that they're cracked and really dry. They have a harsh systolic murmur in the second right intercostal space. You take a stethoscope, you listen over here in the chest, you hear this murmur, you listen to their lungs and their lungs are clear. And then you look at their hip and you notice the right hip seems larger or more full than the left hip. However, it's soft. So that means you kind of pushed on it and you know that there's something called compartment syndrome. If someone is bleeding into a compartment so much that it totally cuts off circulation to that extremity. So you look and assess for that. When you go on the computer, you then look up a couple additional things that are important for anesthesia. So NPO or nothing by mouth for this particular patient has been in for 36 hours. IVF is IV fluids. That's been running at 75 milliliters or cc's an hour. This patient has received oxycodone. You look through the medications, which is a type of opioid pain medication. And you'll also notice that the hemoglobin has seemed to have dropped from 14 to 10 when you do your assessment. Now, what is your anesthetic plan? I want you to think about this in your mind, and then we will go over what I will do. So just think about the types of anesthesia you might consider that we talked about earlier. Okay, so for this particular patient, what I'll say is that, as I mentioned earlier, hip fractures, lower extremity, knee replacements, things like that can actually be done under spinals or epidurals. Some of the things that actually stop us from doing things like that are blood thinners. So a lot of elderly patients are on blood thinners or they have some kind of anticoagulation for their either heart rhythm or for clots, blood clots, things like that. And that prevents us from doing things like spinals and epidurals in those patients because it's dangerous to put a needle in someone's near their spinal cord when their ability to clot their blood is not quite there. So that's one thing. The other thing too is this particular patient, because they have aortic stenosis, it could be quite dangerous to do a spinal or epidural in because that type of medicine can cause your blood pressure to fall very quickly, which is dangerous for this particular type of heart problem. So whenever someone is very, very sick, we typically opt for general anesthesia because we have more control of the situation. So this patient's anesthetic plan, when I work with residents, I ask them, what are you going to do for these areas? So the lines. So this patient will need a peripheral IV. So that's the way that we're going to deliver our medicines. We will also place an arterial line, which I mentioned earlier, allows us to see a patient's blood pressure every single time their heart beats. In a patient that has a heart condition like his, it's really important because if his blood pressure were to get too low, then his heart may stop completely because of this lesion. And so the medicines that we provide in order to send patients to sleep typically cause low blood pressure. It's very important to be able to see every time the heart squeezes what the blood pressure is. If you think about going to the doctor, when they check your blood pressure, they put a cuff on your arm and they squeeze it really, really, really tight. Next time I want you to think about how long that takes, because typically it takes at least a minute, and in a minute's time, someone's heart could completely stop after undergoing anesthesia. So I think it's important to consider certain patients are safe to get most patients just get a regular blood pressure cuff like you would see at the doctor's office, but sick patients typically get an arterial line. For the airway, we will put in an endotracheal tube, and then induction, like I said earlier, means how are we sending this patient to sleep? What medicines are we using? So in this particular situation, the decision was made to use propofol, which some of you guys may have heard Michael Jackson overdosed on it. It's only safe in the hands of someone who knows how to use it, so just be cautious with that. Phenylephrine is a type of medication to keep blood pressure up. And then rocuronium is a muscle relaxant that allows us to facilitate getting our breathing tube in. So you give anesthesia and the blood pressure is 40/20. That's not a good blood pressure. So we're a little concerned now. The decision is made then that the case is not going to be done. So they're given some medications to bring their blood pressure back up, also known as vasopressors. Those medications continue on. And because he's on these medications, he needs to go to an ICU. He can't just go to a regular floor where he came from. Now, what happened? Why did this patient suddenly have low blood pressure with propofol? Well, what I'll tell you is aortic stenosis is a very, very dangerous lesion for anesthesiologists. It's an area where if someone tells an anesthesiologist that a patient has aortic stenosis, they suddenly get more alert. And what aortic stenosis is the aortic valve is the last valve outside of in the heart that stops blood from going into the aorta. So typically when your heart squeezes, the aortic valve opens and the heart goes out into your aorta and to the rest of your body. If you have aortic stenosis, in medicine, we're not very creative about our names. So stenosis means smaller, right? So the aortic valve gets smaller. It means that the heart needs to squeeze harder in order to get blood across this valve. So that's why it becomes dangerous, because if the heart doesn't have enough pressure or blood to squeeze the blood forward, not enough blood goes into the aorta, and that means not enough blood goes to your brain, to the rest of your organs and your body, and that is bad. Because the goal of your heart is to be able to perfuse or be able to push blood, oxygenated blood, all around your body. So in this particular situation, this patient, it was determined, actually was bleeding pretty significantly from his hip. And blood loss can really impact a patient's ability to maintain their blood pressure. It impacts the ability for the heart to squeeze properly. So this particular patient came to the ICU. We determined that they needed some blood. And so they received some blood and were able to come off of those vasopressors. That means those medications that increase blood pressure. After a few days, it is decided, because there's actually some studies that show that you have to fix patients' hip fractures. There's certain things that you don't need surgery for, but typically hip fractures you do, because patients with broken hips are in significant pain. And frequently, the studies have shown that elderly patients with unfixed hip fractures end up dying from delirium and other complications of hip fractures at a higher rate than if we were to just fix the hip. So that's why it's important to proceed with these surgeries. However, on the day he's going back to the operating room, he goes into something called atrial fibrillation. With atrial fibrillation, this has actually been made more popular now that everyone's got an iWatch and can check for atrial fibrillation. But what it means is that the heart, which has 4 chambers of blood, the atrium are the 2 top chambers, and then the ventricles are the 2 bottom chambers. The atrial fibrillation means that where the electrical activity of the heart starts, normally the electrical activity goes down the heart in a very organized fashion that allows for it to squeeze well. If you have atrial fibrillation, instead of squeezing nicely, so normally the heart squeezes kind of like this, and atrial fibrillation, it just literally fibrillates. As I said, in medicine, we're not very creative, so it fibrillates. And that's that looks like. So it's an irregular rhythm. If you want to try to diagnose atrial fibrillation, frequently on physical exam, if you just palpate someone's pulse, you can notice that it's very irregular. If you palpate your own pulse now, the likelihood is that it's pretty regular and that you're in normal sinus rhythm. So this patient goes back to the operating room, and anesthesia team decides on this plan. So again, he's going to have a peripheral IVs. He's going to have an arterial line. We're still going to do a breathing tube. But this time around, we decide to use a different kind of medication called etomidate. This is another kind of anesthesia medication that typically doesn't lower blood pressure as much as propofol, but has other side effects, and that's why it limits its use in a lot of patients. In this particular case, he undergoes induction with etomidate, phenylephrine, that medication to bring up the blood pressure again, and then rocuronium, that muscle relaxant. The breathing tube goes in, the patient's blood pressure is normal throughout the entire case, and they're able to go ahead and fix the hip. So he undergoes fixation of the hip under general anesthesia. He's extubated, meaning that breathing tube has come out because he's able to breathe on his own and follow commands. And he goes back to the ICU, where he is then discharged to the floor and then to home. And that is my session. So I am all over Instagram and Twitter. I just started a YouTube channel if you guys want to check out some of my thoughts on my journey, other things that have come up along the way that are related to medicine. I talk about it there. And of course, I'm always happy to answer any questions. I see there's a couple in the chat. Do you want me to go ahead and just go through those?
Yeah, or I can read them for you if you want.
No, I can read them. So let me just come off of this. Okay, so in terms of percentage of the time I'm doing solo cases versus supervising, that's a really great question. So what typically happens is there's different practice models, as I kind of alluded to. In my particular model, I spend most of my time supervising. If I pick up extra shifts or every once in a while, I will do my own cases. And I will also say after hours, I will do my own solo cases as well. And so those are the kind of balanced, that's the balance that I have, versus one of my best friends is currently in a practice where they do 100%. Most of the time, if you're in a supervise or supervision model, you will be supervising. It's not typical that if you're in a practice that supervises that you do solo cases. But in my practice, and that's the reason why I like being where I'm at, is that I still have that opportunity to do my own cases, which keeps my skills up, because that's what I'm worried about. If I'm not in the room caring for these patients myself, there are certain skills that will atrophy. So putting in IVs, placing breathing tubes, things like that. These are things, and monitoring things. Those are things that I want to keep my skills up in. So I will go ahead and do my own cases here and there on purpose. And then how often do you interact with patients? Do you ever speak to the patient before you put them to sleep? That's a great question. I will say, some of my colleagues don't feel as strongly as I do about this, but we do have a problem in our specialty in that most people don't realize that the anesthesiologists are doctors because there's so many nurse anesthetists that provide anesthesia in our country. And so I make a really big point. I see 100% of my patients before I usually like to go and do the consent for the patient to answer questions. Oftentimes I like to do the IVs for them just to be able to have an opportunity to show that, you know, an anesthesiologist is quite good at placing IVs. I can't tell you how many times I have patients that'll say, oh, they can never get an IV in me, and I get it in the first try. And so being able to let people know, so I make a point to go and introduce myself as a doctor. I show them my badge so they can see what my face looks like, especially in COVID times. No one can see each other's faces with masks. So I make a point to show them my badge, explain that my role within the anesthesia care team model, and have those conversations. I oftentimes also check on my patients afterwards, because in my hospital as an ICU doctor, I also oversee the recovery area, which is called the PACU, post-anesthesia care unit. And so because I oversee that area, I think it's important for me to follow up on patients and make sure that we did a good job with providing pain medication, and we did a good job with preventing nausea. That's the other really, really challenging side effect of anesthesia, is people can be quite nauseous after anesthesia. So I like to make sure to check in and see that we did a good job with that. I'm happy to answer any other questions if you guys have any. Oh, in general, are there any questions or any challenges with going to a new medical school like OUWB? That's a really good question. What I'll say is not every new medical school is created equally. Different medical schools have different resources available, have different approaches to how they want to set up their curriculum and their classes, et cetera, et cetera. What I found with OUWB was that it was really, really well organized. I also felt like compared to the other institutions I interviewed at, that the faculty were really enthusiastic and really excited about teaching students and making this the best medical school that created and graduates compassionate physicians. And I could tell that from the interview day when I interacted with the faculty members, and that was a big deal to me. And that's actually why when I decided I wrote a blog entry about this actually, but I had to compare and decide between the public medical school in my state versus OUWB. And one of the big tipping points for me was really a gut feeling. At the interview day at the public medical school, I felt like the faculty member was quite disconnected, that I didn't feel support there. I didn't feel that warmth. I didn't feel like I would thrive in that environment. And the most important thing too, aside from I'd say to consider finances, is do you think you're going to be successful among the faculty members that you meet or among the other students that are at that institution? Does that institution's culture reflect what you want to become and what you want to be part of in medical school? Because those things will determine how successful you are in school, and as a result, how you'll do in the match. How do you deal with loss as a critical care ICU doctor? That's such a good question. I think that one of the hardest things is I still remember the first patient that I saw die, and it sticks with you, and it's really heavy and it's really hard to process. Especially since for me, I will say that I have never, luckily, and I'm so thankful for this, I've never experienced loss of a loved one. And I know there are people that have and that have really felt that heaviness, that weight, but I haven't before I first saw a patient die in the hospital. And what I'll say is that some people get hardened by it. Some people really struggle with feeling compassionate after they see a lot of death and see a lot of destruction. I did my ICU fellowship during the peak of the pandemic here in Boston, and it was really scary and it was really stressful. And what I do to deal with it really is to acknowledge I acknowledge the feeling instead of ignoring it. And I also think it's so important to not become hardened and jaded by what you see in the hospital, to still feel that feeling of loss and sadness, because at the end of the day, the family members of patients that we lose really need to know that you care. And that's something that when I was training, I thought was so important, is there were doctors that looked like they cared, and there were doctors who didn't seem fazed at all by it. And the doctors that really stuck with me were the ones that felt for the family and felt for the patient and really wanted to make sure that that was obvious and they were there and there was support available for the family. So I personally say I think about it, I reflect about it, I journal now too about it. And I think these are really important things to be able to reflect on my contribution and my part. You know, could I have done something different or better in order to get to a different outcome for a patient? Were there other things that I can take forward with me? And then after that, you know, I try to move on, because it's important to move forward, but also have time to debrief and reflect. What do you see the field of anesthesiology going in the future, especially now with CRNAs and other healthcare professionals being able to do the work of an anesthesiologist? What a great question. So first and foremost, what I'll say is that the encroachment of other individuals in specialties is in every specialty. So if you look, there are nurse practitioners that do primary care independently. There are optometrists that are trying to do cataract surgery in certain places. There are different kinds of radiology techs in certain states that actually are going to read like chest x-rays and films and things like that. So, and in surgery, you know, we have people, actually, this is another great example, dermatology. How many of you guys have seen on Instagram random people who have not had dermatology training suddenly do Botox and aesthetics clinics. They open these clinics. So I would argue that no specialty is safe from others trying to do the work of your specialty. The flip side of that is I did an ICU fellowship because I love the work, but also because when are you ever going to have an ICU where you don't want to see a doctor there as part of that care, right? If you have a loved one in the ICU, most people are going to look for the doctor. And that's one area where I would say that I feel kind of like I have an insurance plan and I'm always going to have some job there because you are always looking for a doctor there. I think that from a CRNA perspective, I love working with our CRNAs. I think that more minds are better, like two minds or two brains thinking about a patient are better than one. So personally, I think that our patients get better care because I have certain strengths I bring to the table. Our CRNAs have certain strengths they bring to the table. One big strength is that they were ICU nurses before I and have never been an ICU nurse. And so there's certain things about running medications that they know better than I do. There's certain things about offloading pressure and preventing pressure ulcers that they know better than I do. And so that's why I think it's so important to work together as a team, and that I'm not necessarily worried if CRNA wants this kind of practice. I'm okay with that because I think that they can take on their liability as they want instead of practicing under my malpractice and under my license. And so that's why, to me, I'm not concerned about it. And I also would say another piece of advice to all of you guys going into medicine is to think about the fact that how you see us practice medicine today is not going to be the way you practice in whatever specialty you're in, because medicine is constantly changing. And what you see now is not necessarily what it's going to look like in 5 or 10 years. So just be aware of that and make sure you're ready to accept that there's changes. And the scholarship you received, was it offered by your medical school or somewhere else? It was offered by my medical school, and that's why I think it's a good plug for those of you guys considering newer medical schools, is frequently they have more scholarship opportunities available. You said earlier that some patients don't think of anesthesiologists as doctors, so you've ever experienced the same issues with other physicians or coworkers? Yes. So in the operating room, I have many times experienced this where when I'm saying hi to the patient, the circulating nurse will come out and will say, oh yeah, the doctor will be here soon, assuming that the surgeon is the only doctor in the room. And that's something that happens. And I'll say that anesthesia is not a great field for people who need to get attention and need to feel like they are in charge of everything, even though in a lot of what I'll say is in an emergency during surgery, the surgeon looks up to the anesthesiologist to manage the situation because they know that that is our realm of strength, that we are the ones that are calm under pressure and that we're able to handle critically ill, crazy situations of the patient heart were to stop. We're the ones managing their CPR and their resuscitation and their medications and all of these things. And so I love our specialty because we're kind of like ninjas. We're, lurking behind the scenes and we come out when we're necessary. Otherwise, we're chilling back there. We make it look easy, right? But it's not that straightforward. And one of the jokes I like to say, it's like the ABCs of anesthesia, book, chair, right? We sit there, we provide anesthesia, get a book out. Yeah, no, it's not that straightforward, but there are days where that's the case. It's just that it's something where I would say it has happened. And it also doesn't help that I'm a woman. Most of the time, men don't run into this situation. For example, when I was the ICU doctor on a service, I had a male resident with me to go examine a patient, and the patient kept looking at the male resident being like, oh, where's my doctor? Where's my other doctor? Where's the attending? And he's like, no, she's the doctor. I'm no one. Like, don't look at me. And so these things happen, and that's kind of the reality of our current landscape and how life is, but it's changing and it's getting better. So I anticipate by the time you guys are practicing that these are things that will continue to get better.
I have a last question for you.
Yeah.
You did your master's degree before you applied to medical school. Has that helped you in any way, or can you use it after your medical degree to pursue something like research in the future?
That's a great question. So my master's is in biomedical engineering. So what I would use it for would be to get a job as an engineer. So my backup plan was if I didn't get into medical school, I would work as an engineer. And I'll say that I was one of those people that sat on wait lists until May of the application year. So I actually got a job as an engineer in April because I thought I wasn't going to medical school. So that was my approach to things. There's some people that'll get masters to be able to do research later, or like an MPH to be able to do different kind of statistics and big data analysis. But that wasn't an interest of mine. My interest is in clinical medicine, it's in education, and it's in kind of like leadership and administration. So that's why for me, like right now, my master's degree is not something I really use. I mean, I got the training to think like an engineer, which I think is very helpful for anesthesia and to be a doctor, but it's not something that I would use for research.
Thank you. If you guys have any other questions, feel free to drop in the chat box.
Well, thank you guys all for coming on and for asking really insightful questions. I really appreciate it. I hope this was useful and fun. And like I said, I'm on multiple social media channels and super excited to always help you guys out if you have questions for me along the way.
Yeah, thank you so much for taking the time out of your day to speak to us.
Okay.
Bye. Have a nice day.
Thanks, you too.
And for those of you who are currently attending, we will post the Google Form link in the chat box. Make sure to verify your attendance to get the credit for this session. And please try to use one email throughout all the sessions. And with that being said, our next event is happening on April 29th with Dr. Kristen Yates, who is a physician in OBGYN. So stay tuned for that. And thank you all for participating again. Take care.